finally my turn. Okay. This picture is taken last year at Trami. Anyways, this time thank you to invite me or as a PR speaker and board members. Thank you for making this happen this year. So I was a translator and now I'm a presenter, and I'm going to be the translator back again after this, but it's going to be much more easier because of it. Okay, so today what I'm going to talk about is only the 15 to 25 minutes, but the topic is kind of the heavy topic because anterior implant therapy, the preservation or regeneration or prevention. So which is the best or which do you choose for this kind of the material maybe if you need it. Okay, first of all, let me introduce myself very quickly. Most of the people would know who I am, but I'm just, after I came back from California, and I'm just opened up my clinic. It's been 3 years and a half in Tokyo, and I'm just now teaching at Nippon University, and also sometimes I go back to the Loma Linda University. When I was in California, this is my program director, Dr. Lozada, and this is my classmate. He is from Spain. And what I did is, what happened is in California is I finished a 3-year course, or I received a certificate, and also I finished my master's degree. So I got the master's degree over there, and also it was not the specialty in California or in none of the places in California or United States. But it's only the ABOI, which is American Board of Oral Implantology, they provide some kind of the certificate or diploma. So that's why I went through this interview, also the written exams. So I received this diploma. So which one is a pretty good procedure because now they were recognized that one as an implant specialist. So I can say that I'm an implant specialist in California. So, but when I finished my program was the year 2003, which is more than 10 years ago. So there was a lot of things that it's been changing since then. So what happened is that when I started my program, the implant was basically that I started on the heel side. But after that, the people are obviously talking about the immediate placement. And also they're discussing about how deep or it is. And right now we discuss about which location, medially, distally, and 3-dimensionally, but at the time was how deep you did place the implant, something like that. At the same time, the previously they were discussed, but there was a battle gap or jumping gap. We are discussing that how much of the bone space between the bone and the implant surface we can leave, or we need to be putting some kind of a bone material. What kind of the material? Those kind of the discussion has been done in the past. And afterward, it's the center of the screen, we are discussing about the immediate placement. And right now, a lot of cases has been seen in for those kind of implantation. Actually, this is one of the cases I did it for my first patient, and the first implant case in my life was actually the extraction and the immediate implant placement. So it was kind of a tough case for me. And the other thing is of course, also the before, we are thinking about maybe we need to fit the diameter of the implant to the extraction socket, which is sometimes we need to go out to 6 millimeter, or right now sometimes some people saying more than the 6-7 millimeter for the fitting into the gap. But now for the aesthetic or for the anterior implant placement, right now, maybe many people prefer to having a little bit smaller diameter to have more space or more capability of the working space. So those kind of things has been done talking about, and also I'm going to go through this research we've done when we are in the university. And so at the time, we just measured and collected the data from the implants and also the environment around the implant treatment. Also, after that, the previous case in the morning, we discussed about why the bone loss happened because of the maybe good enough bone was around in the implant. That's why the bone resorption happen. Then maybe tissue resorption happen. So how much of the bone thickness we want to have on the buccal side. Those kind of things is, that we have to discuss about. But anyways, this is a very short time of the period. So what I'm going to do is today, what kind of the treatments we provide, we just need to have done. So this is the two patients I presented. The left side is my patient. It's been a while, maybe 10 years after I finished my program. I came back to Japan, and maybe one of the few cases I started doing when I was in Japan. So it's not the perfect, but it's okay. But the right hand side on the screen, this kind of the patient came up to my clinic, and he told me to say what's done about 10 years ago. But he didn't claim anything, and I took the X-ray, but he said, I don't want to do anything with that. And he hasn't gone back to his original dentist for 10 years. So I was thinking, I felt so sad, and I was thinking about what differs those two cases. Obviously, they had a problem. So what is the problem? Those kind of the things what I have to discuss. But before we discuss about those kind of the aesthetic or tissue, we wanted to know what kind of the tissue sterilization around the implant after at least the 1 year after the delivery. So this is the year 2003. We just provided for the research. What we did is we categorized the tissues for the thick type or thin type. And we wanted to know what kind of the thickness of the tissue around the implant usually. So what happened is this one, everything was done with a two-stage procedure because it was before the 2003, which means most of the even anterior cases was done with a staged approach. So what we came up to this kind of the procedure is what we did was a single crown implant procedure under anesthesia, or we just measured. This is not probing. Actually, this is the bone sounding. So we wanted to know how deep or how thick the tissue is around the implant. Because those kinds of the cases after 10 years, after at least 1 year of the delivery, which means the tissue is kind of stabilized. So we wanted to know what kind of stabilization on those kind of locations, the 5 points around the implant, for the facial side of the implant, and the mesial side and distal side of the bone, and also the adjacent teeth. And it's just facing to the implant space. So those are the places we wanted to know where and which portion has how much of the thickness of the tissue around the implant. We know all the tissues around the natural teeth. I mean, we have maybe 3 or even 5 or those kind of the biological teeth, so-called. But we believe the natural teeth and also dental implant hopefully working same way, but actually reality is not. We already discussed about those kind of things. So as we can see, the numbers is relatively much higher than the natural tooth. So we can call it very deep pockets. So those kind of the things that we have to deal with for those kind of dental implants. At the same time, this research find that what we do is interproximal bone level next to the implant is very deliberate, driven by the adjacent teeth. So which means we know if we want to keep the interdental papilla, we want to have a good attachment, a good bone level of the natural tooth as well. Maybe that's the reason that we have the adjacent implant like previously they showed, and maybe we might have the good, easily get the black triangle. And also we see that like a biotype of the thick biotype. The tissue is, of course, it's more higher on the D, so we have the more pockets, and also we have the more stabilization for the pockets. Actually, it's the same of the organization. So after this one is year 2010, Dr. Morimoto, which is a junior, which is coming from the Kyushu area, and he did a research of the physically counted and measured the thickness of the gum tissue when they were doing the extraction, and they found it out about the range of 0.6 to 1.5 millimeters. So actually, those kind of the thickness is very, very thin. Maybe we were hoping because we have the thicker the tissue, but I think it's if you go to the sushi place and if you ask the chef to slice this kind of the 1 millimeter of the maybe toro maguro, maybe it's very, very difficult to deal with it. And upward, also what happens is this one is because of the measurement from the Caucasian people or the foreigners for as a Japanese. So what happens in my experience, that's my opinion, but I think it's maybe for the Japanese people, even though if we do the same kind of data, maybe the number is going to be significantly lower. So we have to be really careful about those kind of cases. So going back to this case, so what we can do for these kind of the cases. So actually, from the research from old one, Dr. Gureger did this kind of the paperwork. But what happened to the implant itself? You know, that previous patient also that he had like a off showing, but the implant is still there. So actually, it's not success, but it's not loss, implant loss, because from the data, the implant loss is only 2.7%. So this number is kind of low. But the only thing is a lot of the research reported was aesthetic complications. Those kind of what is complications is those kind of modification, poor shade, gingival recession, exposing the metal margin, part of the implant or visible. So which is that something happened to one of the patients that came up to my office. Percentage almost 10%. One of the 10 patients that implant is still there, but for aesthetic zone have the problems. So that's the things we have to deal with it. Because of the things, why it happens is because of maybe the nature of the anterior maxillary region. What happens is maybe anatomical structure is very limited, maybe thin, blood supply is so limited, so that's why it's hard tissue or soft tissue. It's very hard to just grow back again. So it's almost sometimes we think it's impossible. Or sometimes we can just surgical limitation is also the kind of that the patient can see is very easy. So that's why maybe we have to work very nicely, otherwise the patient can see easily. And also the since also previously it is explained, patient's demand in the front case. I'm going to get married I'm going to get married soon, so that's why can you get it done soon? Yeah, those kind of things is very just pushing us, very just limits our the situation. Because of the surgical the limitation, we all know after the extraction of the front teeth, what happened is from the data, we already know about those. Vertically, horizontally, we lost the volume. It doesn't matter for the patient sometimes, but for us, if we have to do something after this, it's very low. So after the first 3 months, most of the volume loss happens to about 2/3 of it. So those kind of things, that's why we have to do something for the anterior regions. Audience response result, which is like a big meeting or AAO meeting. There was an audience like this, and some people asked me the question, and they could push the button, what kind of the question they wanted to know. So they came out to this, what is the most difficult procedure or consideration of your clinical work? Then they came up to the vertical ridge augmentation. Most of the less than this, a little bit less than half of the people. Maybe this, if I ask you, it's the same thing. Maybe it's the same kind of numbers of people who are going to raise your hand and wanted to know what's going to be done. Also, this one I showed one of those the research, not the research, but they categorized one of the case for the anteriorly vertically missing the space. Then how to deal with the bone graft, tissue graft, those kind of things. This one done by Dr. Urban Eastman. So he is one of my friends when I was in the United States. He was taking a fellowship, and he is from Budapest in Hungary. And he provides a good course, and also sometimes he comes to Japan to give. But maybe some of the audience that has been attended his meeting, his lecture also. Then he said that he categorized it and what the kind of the procedure need to be done, and he pointed out the right side on the screen. There's a difficulty, and And that what they say is that other than type 1, it's sort of difficult and the moderate and the difficult. So for me, even the urban, if he categorizes this one is difficult, it's extremely difficult for us. It's extremely difficult for me too. So actually the vertical and the bridge augmentation is very, very difficult situation. So we have to, we can spend a whole day. So, but I don't want to discuss about this. But maybe we wanted to have something that's more non-invasive or more reliable procedure because the Japanese people they have a tendency not to have it, don't want to have the surgical procedure. So that's why we can preserve, or we wanted to do something like that. The way I manage the cases for the anterior cases, that I see with the 3 layers of the maxilla as a consideration. One of the location is apical location, which is like if there's a apical lesion, we have to deal with it and then we can consider about the placement if everything goes well, or tissue volume. And the middle part is cervical, and we see the attachment. From the research, we need attachment or for the adjustment the teeth or the good bone architecture from the cervical area. And the superstructure is something that we all know about the kind of the material. And those kind of things, we also will have to have some kind of a 3-dimensional image right now. And previously, we can just manage the case. Try to put on the implant. Where you want to place implant, then if there's no bone, we have to work on the graft material, graft procedure. The reason is that we have to go through the 3-dimensional. If this is one of the research you were saying, also the Homonida. Sorry, everything is from the Homonida because I just wanted to just collect all the data what we provide for the community. In 2011, we measure what kind of this is that's the healthy natural the people from the canine to canine on upper and the six front teeth with 100 patients just measure count. So where the location of the roots. So which implies that this is before you do the extraction, we know what kind of a location they have and what kind of the procedure. If we can provide or if we can preserve the tooth structure before the extraction, but after the extraction to do the implant, we wanted to work on that. So we have to be ready for that. So that's the reason, and we wanted to know. And look at this, 81.1% of the people has those kind of shape. So we are just lucky about it if the immediate implant placement is applicable. So we wanted to know what kind of the treatments we wanted to know. So what is your choice? Either the preservation or making everything from scratch, which is the reconstruction, or prevention. Maybe prevention is the easiest, but sometimes it's very difficult to work with. So preservation is something that, so of course, if we go through the diagnostics, and also we have to make the good treatment plan, and if possible, I think this is the best way. But of course, you need to have a lot of good selection about that. And after that, of course, the extraction needs to be atraumatic. So we do the extraction, and the placement of the implant needs to be 3-dimensionally, not only the depth, but the medially, distally, buccally, linearly need to be done. And after that, bone needs to be placed to fill the gap. And usually, at this moment, for me, 2016, maybe the soft tissue graft is necessary to build up for the implant immediate placement. And healing abutment will be placed and no immediate loading. So of course this one is a healing abutment, so that's why some people say like some kind of the loading is applied. Maybe that's true. But for me, I just don't want to do that. When I was a student, I put the crowns and take pictures, and it looks like it's very nice. But for me right now, as just a clinician, just having a clinic, this works very good, and I can control with the temporary provisional crown, unless the patient wanted to get married in 2 weeks. Okay? If we have the good enough time, maybe we can work that. So what I do is, usually those kind of cases, the adjacent teeth are the natural teeth. We have the super bone, which is very nice. It's very nice. So I just don't want to do anything bad. I just let it heal for 4 to 6 months. Then after that, we can just start working on it. So we're thinking about advantage of the preservation, those kind of procedures. Of course, we can maintain the architecture. We don't need to retrain the architecture of this kind of procedure. And also for the patient, the surgical procedure is only one time. So they don't need to worry about it. That's it. So this is a good advantage for that. And also the ridge contour can be preserved. So also the same things. So not only the soft tissue, bone, everything can be preserved. But disadvantage is, of course, the case selection is very limited. That's very limited. And also you have to be very strict about this. Otherwise, you're going to have the problems. So you don't want to have the problems. You don't want to do those kind of things. And also that's why if you don't want to have done it before, maybe I don't recommend. But I cannot say because in the first case I did in Japan all my life is my extraction and knee replacement. So maybe I'm the exception, but I don't want to. It's kind of difficult for a patient to make feel comfortable if you were the first case. But if the reconstruction case, of course, if the patient the tooth needed to extract it, of course, we do the extraction. And I did the bone ridge preservation, but it didn't work. So of course, it was just previously preparation for a bone graft. So after the tissue healing, I did the block graft. Then I placed the implant. Then the vertically, horizontally, it is restored. And also the same thing is we mentioned implant were placed in the correct place. And soft tissue is maybe necessary because most of the time we lost the hard tissue and soft tissue at the same time. So two-stage implant is also the I prefer to have because I don't want to mess up anything if we deal with it for the last 8 months or 10 months. So that's the good thing about this the construction advantage is the picture is the more ideal position. So we, to begin with, we located with simulation with the CAT scan. We wanted to have the dislocation. Then to place this implant, I need a bone. So then to start with. So this is the big advantage. We can place the implant ideal location. But this advantage, number of disadvantage is a lot more than the immediate placement. So, but still, it's a lot of the disadvantage. So we have to consider about it. Of course, the preventive dentistry also the same thing is the oral hygiene necessary. But what we are talking about in the implant dentistry for prevention is we have to prevent a lot of the tooth loss or failure because after the root canal, patient comes to several times wiggling, stabilize, comes out, stabilize, then eventually what happened the bone, the fracture on the facial side. So we have to consider about those kind of the implant placements. So we want to control the occlusal, and also we don't want to have any kind of the trauma to lose the natural tooth. So of course in the implant is necessary to prevent or to protect. And sometimes for the loading or the heavy loading, we have the bone loss or implant fracture or the surgically. Sometimes the implant works strong enough, or technically the surgeon will apply too much of the forces and the implant breaks. Those kind of things we can prevent. And also we can discuss about the whole day regarding about the prevention of peri-implantitis. But those kind of things, of course, it can need to be applied for those kind of prevention. What I like, and also the aesthetic complications, 10% of people from the past, from there is there. So we have to mention about if the patient is not the candidate for implant treatment, we have to consider about something different. And the last thing is prevention with patient education. So I'm sure it's, they count is for the maintenance, how many times, maybe in 3 months, one time per 3 months or every 6 months. But the patient is working or brushing every single day. So educating the patient is very, very important as well to prevent the not having the implant or once having the implant to have the longevity of the implant. So the last thing is like, so eventually what you want to choose is actually, it really depends on the patient's chief compliance, always comes first. So what the patient wants to do is very important. We have to consider about, and then we have to do whatever that we think is that just we need to do, or what we have to do. So it all depends on the patient's the chief compliance. And the treatment plan, and we have advantage and disadvantage of the procedure we just went through very quickly. And right now, this, if the CAT scan is available, maybe it's better how everything is with a three-dimensional image, and also that planning need to be three-dimensional. Yeah, and also that you have your own assessment. Once you build up your clinic, maybe you keep doing it, and if you believe that you are doing okay, just keep doing it. And the last night, we saw a lot of magic, nice magic. Okay, but the Masa-san can do the magic, but there's no magic in dentistry. So we have to work on that. Thank you very much for your attention.